Thank you very much to all of you, to all the speakers for these high quality lectures and for these very informative lectures. We will start with the questions, and please use the window next to your screen to send us your questions. I will start the questions with Basile Lantis, and there is a question. What is your opinion, Basil, about the four-phase rhinometry?
Oh, yeah. It's, can I hand that question to the audience? Because it's like, do you believe in God? It's like tests are there to be used, and the message was not so much you need to use that and that and that. I think the most important, and I hope this message has been delivered, is that tests are tools, and if you use tools, you need to know what a tool is able to perform in the situation you need an answer, So I would have a very pragmatic approach. All of these tests are good, and all of these tests have shortcomings. And I think it's very much a story about what an indication would be, and what is, I'm against routine testing, for instance. I think that came out of my presentation, and so this is it's a very absolute question. So it can be good and bad. Let's answer like that.
Can I say something to that? Because I totally agree with Basil in terms of we should do a test if this test will change our management. No doubt about it. However, if I had to make a choice between the classic rhinomanometry and the four-phase, I would choose the second one. Why? Because it is strange. If you see, you have all these beautiful curves with the classic rhinomanometry, and at the end we use only 1 point, the value at the 150 pascals. So this is the opposite with the four-phase. That's why I think it has better matching with the subjective symptoms. Of course, it's only a tool, and you have to use it when something, it's not in our mind, it doesn't fit with what clinically feel, not in normal cases. However, I think it's better than the classic rhinomanometry. That's my opinion.
Diljana, would you ask the next question?
The next question to Professor Skading is, what is the sensitivity to discriminate non-allergic rhinitis from allergic rhinitis by means of NO measurements?
That's a very good question. And the paper that I gave the reference suggests that if you do a ROC curve, the sensitivity is extremely good. It's around 0.8, 0.9. I think people need to go away, read the paper, and see what they think.
There is another question for Basil. What is the biggest disadvantage of PNIF? Basil.
Yeah, I would like to refer to what Gladys said. I think she pointed that out very nicely, and partly it's also in my last slide. Is all these tests are tests done by somebody. So if you have a very lousy technician, or then all the tests are worthless. Even a pure tone audiogram, that this is, if you have a very intelligent technician working with you for years and he's trained, and you give him a feedback, then almost all these tests are very valuable. So I think we have really it's like radiology. Pressing on the button and do a scan is objective, but interpretation of a scan is highly dependent of the radiologist. So, and all these tools are the same. So I would say, to be very brief, Gladys told it. There is one problem with the Euler collapse. Second is the willingness of patients. Let's say, Gladys, do you have anything to add?
I think the seal between the mask and the face is important, which is why, exactly as you said, for years I've worked with the same nurse who does these measurements for me, and she holds the back of the patient's head, she pushes the mask on, and you get very good reproducible results. We always do it 3 times and make sure the results are reproducible.
That's maybe one thing which has to be stated. There is an accommodation or training phases. The first and the second sniff are very poor up to the moment when the patient gets what you're asking about, and it's not, you know, if somebody is simulating, you cannot help, you cannot overcome that as well. So it's
I think another problem is the nasal valve collapse.
Yeah.
So if you have a nasal valve collapse, then it doesn't work. Yeah. Maybe you can use it as a failure just to estimate that there's a problem with the nasal valve.
I may add something. You know, maybe I can say how we do it in Geneva with all these functional tests. So of course, I really liked Gladys' talk. I liked all your talks, but I like the fact that you have to stress the history, you know, and then a careful exam. These are the cornerstones of every investigation in everything in medicine, but of course also in rhinology. And then once you have made up your mind, let's say turn it that way, then you can go back and or add extras, which are tests. And we really selectively use these tests in cases where it is, we don't use it for things where it is very clear for me what the problem is. You know, the guy who has septal deviation on one side and he's complaining of that side, and he's 25, and I know when I do surgery, he will be fine. You know, that is not the person that gets none of these tests. But if I get somebody in my outpatient clinic and he has a straight septum, has been operated already once, and he's complaining of maybe obstructed nose, so I say, "Ooh, what is that?" You know, anatomically, I don't see what it is. Is there a trigeminal problem? Is it maybe a very anterior alar problem? Then I go, and then we usually do all the tests. That means that we go for TIF, lateralization test, and rhinomanometry. We even sometimes, we have patients, they complain about the fact that they would have the nasal congestion when they lay on their back. And so now we do even rhinomanometry when they are lying 15 minutes or 20 minutes, and just to corroborate that, you know. So we rather use them to understand than to do diagnosis, and it's still approximation. All these tests together, sometimes they give you a clearer image of what happens, and sometimes not.
Professor Schading, what is the percentage of healthy people without symptoms having positive skin prick test in aeroallergens?
It depends on the allergen, but for example, I've heard the figure that about 30% of people will have a positive to house dust mite. And that is of the general population. And they are not all affected clinically by it, which is why I think if you're thinking about doing allergen immunotherapy for a patient with a positive house dust mite test and bad symptoms, what you should do is a nasal allergen challenge to make absolutely sure that the extract you're going to use is something to which that patient does clinically react.
Professor Constantinidis, can I ask you something?
Yes, please.
Sure.
Can you do trigeminal training as we do in olfaction?
This is a really interesting topic. I was thinking about it, to be honest. And actually, at the moment, there is only one paper, of course, from Thomas Hummel. And so what the authors said is that, yes, after 70 days of training, we can have better results in the trigeminal sensitivity, mainly in normal subjects. This difference was not really clear in patients. And it is a new topic. We work on it. Actually, I started to see if trigeminal training is working in empty nose syndrome patients. But unfortunately, at the moment, we have a small number of patients following this scheme. And although they say that, okay, for a while we feel better, this is not permanent. So maybe we have to change the timing, how long we have to train people. We'll see. But it's something new, and maybe there is a basis for new studies.
So I think we have to go to Professor Hummel. There is a question, Thomas, which part of olfactory test is more decreased in nasal inflammation?
Thank you. I think I said that in my presentation, that it's the odor thresholds. So of course, it's like there are exceptions to that, but if you see a difference, then it's typically would be odor thresholds that are decreased or that are low, and odor identification, odor discrimination would still be okay.
Biljana?
I don't have questions.
So there is another question. Are there any patterns of olfactory loss in different disorders? Loss of pizza smell in Parkinson's disease?
That's a good question. That's an interesting how long living references or citations can be. I mean, that was published by Dr. Hawkes in 1994, 1995, I think, in Lancet, so very well published. Very nice figure in there. So between Parkinson patients, all the odors were aligned, but pizza stood out. And she said, it's the pizza. And you just have to present the pizza odor to subjects, and then you know they're Parkinson's or not. It's very catching. And this is why many people also memorize that. But there have been a couple of studies in between, more or less showing that this is not so. So if you want to, it's not one specific odor that is often Parkinson's. There's not a Parkinson odor, or there's not an Alzheimer odor. So that's a little bit problematic. Or it would be nice to have an eosinophilic rhinosinusitis odor, but this doesn't exist. It's not really there. What you have to look at for patterns like odor thresholds, odor identification, there can be something differences between orthonasal, retronasal, but also these patterns are kind of vague, so it's kind of, it is there, but not 100% reliable.
There is another very interesting question, Thomas. In hospital emergency setting, which test can be done for anosmia due to COVID-19? I think this is a very trendy question.
Yeah, that's a good question. So it depends. Yeah, so you have to ask your subject, how about the sense of smell? Then you get a rating, which can be quite informative. Then there's because when these people are potentially infectious, then you would like to have a disposable test. There could be like an OPSIT-like test, like tests that are also increasingly becoming available with one odor on it or like 4 odors on it. So a very quick test can give you a lot of information. And of course, after the acute phase, then you can use more elaborate tests that also are not disposable. But typically, I would say when you have a patient who comes who is suspect of COVID-19, also visual analog scale, that's very helpful, asking the patient and having like a very simple, either like one odor, there could be a pen or a bottle in a standardized form, an odor identification test, or a very simple 4-item OPSIT test.
Another important question is for you, Jordanis, and for you also, Thomas. Can you do trigeminal training as we do in olfaction? I think this is also an interesting question.
I think we already answered to that. It's something that we work on it. There is only one study, as I said, with some positive things, but we'll see.
Okay.
Yeah. There's only this one study, and it would be nice to have a trigeminal enhancer. So something that really enhances trigeminal sensitivity for a longer period of time. But do you know anything like this? Like a menthol compound that is increasing trigeminal sensitivity? So I've been looking for that, but I haven't seen anything. Maybe you're aware of something? Jordanis?
Or maybe it's a matter of how we perceive the odorant. I mean, through orthonasal or retronasal, through the mouth. Maybe it's more behavioral. I saw a paper, I think it's coming from your lab, about people who used to menthol chewing gums, and they had better sensitivity in menthol. So if somebody is using this for a long term, maybe has better results. But we have to test it we'll see in patients. It's something different.
I have also a question for all of you. Is there any explanation why azelastine works in idiopathic rhinitis? Is there any explanation?
I don't know if Glenis wants to answer to that, and then I can say something.
Okay, I mean, azelastine is not only an antihistamine, it also has other activities, including being an anti-leukotriene, and I think it has some activities on receptors that Ioannis will tell us about. Please explain about the TRP.
At the moment, the evidence we have is that azelastine, except the antihistaminic use, that can reduce the local levels of substance P, which is a really significant peptide for the local nasal inflammation. On the other hand, we know that the subgroup of afferent nerve fibers in the nasal mucosa express actually the histamine 1 receptors. So maybe it acts both ways. And the other, I think, is the new thing in the field concerning the bitter receptors is that azelastine maybe is, under brackets, a bitter substance, meaning that has the ability to activate the T2 receptor family in the same way as chloroquine. There is a paper on it, and it's really interesting to check this in order to understand. We know clinically that azelastine is a really good medication for idiopathic rhinitis, but now we'll have to find why.
If
okay,
there
can
is
I ask Caroline one question? What is the best nasal sampling test to give indication for biologics?
I think it should be a test regarding the tissue. So biopsy is probably the most appropriate, and usually it's samples from surgical procedure that you can use.
Is there any comment from the speakers or any question from the speakers? Professor Scadding, yes?
Can I ask whether there's any evidence about olfactory training in post-COVID loss of smell? Does it help?
If I may answer, I try to answer currently, as I know, there's no evidence for that. It's just in analogy to other post-viral olfactory loss that olfactory training is not, it is sort of amplifying recovery. So it's not a wonder thing that you can do, but it amplifies olfactory recovery to some degree. And I guess one could expect the same for COVID-19. But there's no study, no controlled study out there yet, at least not to my knowledge.
Okay, because doesn't COVID act via the sustentacular cells rather than actually damaging the nerve? So is that different to other forms of post-viral loss?
I guess that's also not known. So could also be like influenza virus could also go the same way, you know, that also, but I don't know whether this has ever been looked at. So I don't know.
Okay, thank you.
One of you knows that? Caroline, Basil, Ioannis?
No. What we know is that the putative entries are the sustancular cells, because they have the receptors, so the neurons themselves will not be affected.
But thinking about other viruses that
yeah.
loss. But I'm not aware that anybody looked at it at a molecular level.
No.
One practical question to Jordan: which is the trigeminal test that could be part of everyday clinical practice in outpatient settings?
To be honest, my talk was a trigger for further studies because nothing is really commercially available at the moment, and it is really hard to standardize this kind of test. But if I had to make one choice, I would say the lateralization test, which is an easy test and more or less has been tested in many studies. We know somehow normative data, and all the other tests need further studies to have normative data to be standardized, etc., etc. So if I had to add something more, I would say that maybe a threshold test, like what we used with Caroline in the trigeminal sniffing sticks test. It's because testing threshold, you see in the periphery. So you see in the nasal mucosa, maybe it's easier to find differences in nasal pathology. And in a rhinology lab, you can test all the common disorders with it quite easily.
There is another question I see. Can we use technetium clearance for mucociliary function?
Yes.
This brings us back to the Messerklinger time, you know?
Yes, it's also a technique that is available, but saccharin is probably easier to do. Yeah.
Okay. So if there are no more questions before I give the word to Jordanis, to the organizers, and Iliana, please not forget, as Jordanis mentioned at the ERS meeting in September, we postpone it end of September. We will have a large number of panels dealing with allergy, olfactology, rhinology, and please pray with us to have a better situation after 7-8 months, to have no more COVID. I hope to see you all in real life in Thessaloniki, because I think webinars are very interesting, are very helpful for education. But, you know, meetings, conferences are also socializing, and it's something special. So hopefully we will see each other end of September. And thank you, Jordanis, and thank you, Diliana, for the opportunity to be a moderator in this excellent panel. Thank you.
Diliana?
Thank you, everybody. Thank you for your kind invitation. I also hope that we will see together in September in Thessaloniki for ERS 2021. And we have to stay close each other all the time, because we are a big rhinology family and we have to support each other. That's why be healthy, and I wish you success in your life.
Thank you.
So what can I say after this exceptional webinar? The last information is that we had 589 participants. So this is a large, really number. I have to say that I'm really honored to have such a special faculty. The webinar had a great success, but as Yannis said, it's a webinar. So I missed you. I really missed you. To see you in contact, and I hope to see you soon in Thessaloniki or in other congresses, just to leave the pandemic behind us and continue our good scientific work. Thank you very much again.
Thank you very much.
Thank you.
Bye.
Goodbye.
Bye-bye.
Bye.
Bye-bye.
Bye.